And I also need to, can I do it where there's not a transcription? I think it's always, I guess it's just, I can get it out the window. Okay. The one other thing is I need to make sure that you guys can share screen. Okay. Can you guys try to share screen and see if that allows you to do anything? I mean, we don't have to start yet, but I just want to make sure that I'm not sure if I always know how to do that part. And you might now be muted.
It says I'm sharing. I don't know.
Oh, okay. Yes, I can see it and I can hear you. So everything is actually perfect. So, okay, good. Okay, so just some housekeeping as we start. This is all being recorded. I think Mary and Jessica are running a few minutes late, so I don't have anybody else to help me allow people into the room. So I'm going to kind of make sure I'm admitting people as they enter to the waiting room for the teams. As I say all the time, if you notice you haven't gotten an invite from me within a month or two, please reach out to me. We recently accidentally kicked Dr. Brakel off the list. I don't know how that happened. So make sure that you, and I think Dr. Sarkin was kicked off the list. So just, I don't understand how Outlook does it. It just sometimes gets rid of people. So make sure that you're always getting monthly invites at least. And like I said, we don't always have rounds. If there isn't a case to discuss, we will not have rounds that month. This one is a little interesting because we have kind of noticed a scenario of 2 concurrent morbidities. And so we're going to discuss Gizmo, which is a recent biopsy from Friendship, but then we'll kind of do a quick overview of the other ones that we have in our database of a similar clinical presentation. And I'm actually fine if we want to start using this scenario of rounds to discuss a case and then use it as a jumping off point for what can we do for future research. So we don't always have to have 2 cases to discuss. We usually do 1 case pretty thoroughly and in depth, and then sometimes I'll just show a gee whiz lesion. But I'm also happy to use this as, you know, a springboard for us to discuss about a certain type of disease, and then figure out from a future direction standpoint how we can gather more cases, get the cohort to be larger for publication, whether it's retrospective, obviously usually retrospective case series. And then, you know, if somebody here is interested in taking it and launching it with what they want to do, especially a lot of the trainees that attend this, that's always a great opportunity. So I'm happy just to have 1 single pretty meaty case, dense case, and then using that as a launching off point, I guess. Okay, so I'm still in the scenario where I have to let people in, so I've got to kind of mute myself and pay attention to that. But if you want to start, Dr. Skinner, I think you presented 4 of our most recent 5 cases. So I think maybe you get your 5th biopsy free. I don't know. We're gonna have to do something to reward you for your participation. And we'll talk about Gizmo.
All right, cool. And everyone can see this screen okay?
I can see it. Yeah, I can see your PowerPoint.
Okay. So Gizmo is a 1.5-year-old male neuter domestic short hair. He had initially presented to his primary vet with a 2-week history of PUPD, and then just weight loss, generalized muscle wasting, and a decreased appetite. He had an actual direct litter mate at home who was unaffected. They did some initial SNP testing. He's FELV, FIV negative, indoor only. And on his initial physical exam, they found that he was mildly hyperthermic, had a heart murmur, and had lost the 0.7 kilos over the last year since he'd been in prior. On his initial labs, he was anemic, he had a mild leukocytosis, and he was newly mildly azotemic. We did not have any baseline labs because he was a young cat and they hadn't gotten anything when he was first neutered. But his SDMA was just a little bit at the high end of normal. His albumin was at the low end of normal. But he was azotemic, hyperphosphatemic, mildly hyperkalemic. And then on a UA, they found that he had 3+ protein, minimally concentrated urine, some granular casts. And at that point, they ended up sending him to Friendship. By the time he got to us, he was no longer hyperthermic. He was back down to normal. And then we repeated some labs. He had a very high pro-BNP. Our potassium was normal, and the RDVM hadn't really done anything. He just come up to us the next day and was still mildly anemic. And this was all through our urgent care service. So we got an ultrasound. The kidneys were relatively unremarkable. His entire urinary system was relatively unremarkable, aside from, I think they noted this, some hyperechoic fat within the renal pelvis, some mild dilation, a little bit of peritoneal effusion. And this is his kidneys that first day through urgent care. He ended up staying overnight on IV fluids and some anti-nausea meds. Rechecked his values the next day. His creatinine had come down a little bit. It had been 3.5 before. His BUN was essentially the same. He was now hypoalbuminemic, and everything else was relatively static. So there had been concern on his initial urinalysis for bacteriuria. So they ended up putting him on enrofloxacin and then sending him home on marbofloxacin. I'm not sure why they dewormed him, but you can never go wrong deworming anything. And he was feeling okay, so they sent him home. He visited his RDVM again the following week. He seemed maybe a little bit brighter, a little bit better of an appetite. His physical exam remained unchanged. And then when they rechecked his labs, they found that his anemia had worsened. His creatinine was static. Everything else was fairly static. And then they repeated a UA and found that he was still quite proteinuric, no evidence of bacteria. His urine culture had come back at this point with no growth. And then they actually got a UPC on him, which was 10.9. That was his first UPC. And he did have an elevated urinary cystatin B for unknown importance.
And Steph, if you pause there for a second.
Yeah.
So, we weren't involved at this point. This was just being managed by our emergency service. But when I look back through the records as we did now, because the vet after this visit called us to say, things are not better, where can we go from here? The cat was being treated for presumptive pyelonephritis based upon an automated analyzer saying suspect bacteria, never being confirmed by any person who wanted to look at the urine. And things they just didn't really fit. Like, even if we say, okay, this cat has pyelonephritis, well, then we have to come up with another reason for why this cat has hypoalbuminemia. Is it possible that the cat could have such severe pyelonephritis that it was just having an interstitial nephritis and developing some alterations of glomerular permeability and having albuminuria as a result of it? Maybe. I don't generally see pyelo cause hypoalbuminemia. So I guess I wouldn't say that it's impossible, but I don't think that clinically that checks off a lot of boxes. So I would still be quite concerned about another cause of the cat's hypoalbuminemia. And there really wasn't one that was even investigated. So when we look back, the albumin was kind of just ignored. Like, no one really made any accounts of it. And instead, the cat received antibiotics for what turns out to not be pyelonephritis. The urine culture is negative. The ultrasound even though it's a very insensitive test, was not very suggestive for it. And the cat just essentially got some supportive care without really getting to the bottom of things. And I understand that that's why we have our position and why we have job security. But looking back, just a little frustrating. This would be a case that at a minimum should have had a good in-hospital consult with us so that we could help with things. I think it was probably here like over the weekend or something.
He went on like a Friday.
Yeah, so we weren't necessarily around, but I also think that in the hands of our peoples, we probably would have interpreted things differently and probably would have managed the case differently, because I think seeing the referring lab work that we got at this point, this is not surprising whatsoever. There wasn't a UPC in the initial labs, but there was 3+ protein. There was, I think, trace glucoseuria at that point. The kidney values are essentially the same in terms of a GFR perspective. And the albumin has gone back up a little bit, but it's still low normal compared to where it was at the initial presentation to the vet. So the cat has essentially gone a further time, but nothing has changed because we really haven't treated it.
How often do you see pylo in cats?
Well, I guess I would say, how often do I have a strong clinical suspicion of it? Not commonly, but I would argue the same is true for dogs. Like I think pylo is not as common as we likely think it is.
I agree.
Any patient who has like a small bump in their in their creatinine, that's certainly on our radar, but actually having confidence that that is the cause, I'm not convinced. And I'm not convinced that just by putting them on antibiotics and seeing that their values get better also means by default that that's pylo, because they could have had an AKI that they recovered from, and they just happened to get amoxicillin at the same time, which is not going to be a therapy regardless.
I do think from a pathology perspective, we diagnose it. We diagnose kind of like that inflammation around the pelvis, maybe a little bit around the papilla. And I don't always think it's true infectious pyelonephritis. I think it's sometimes just a little bit of inflammation around that area. And so I think even the literature that has pathology in it is probably some cases that were not true ascending bacterial infection or an actual bacterial or infectious pyelonephritis. I think sometimes it's just, I mean, it is a nephritis. It is inflammation in the pelvis and the renal papilla, but it's not, it could be from obstruction, from reflux, from, a little bit of crystals that are embedded in the papilla. And so I do think that pathology sometimes over counts those cases.
Yeah. And I think when you look at the one retrospective in dogs, right?
Mm-hmm.
It was, I think, 3 centers retrospective over a decade, and they had
and they had like they had kind of make it
Now, granted, most of those patients were necropsy patients. I think they had pretty stringent gold standard of either having a positive culture from a renal aspirate or pylocentesis, and I think that that's awesome, and might reflect maybe how challenging it could be to really definitively diagnose it. Because if I have a strong suspicion, if I have what looks to be purulent material on ultrasound in the pelvis and a positive culture from the bladder, I might say, I think that there's pylo, but I'm not going to bother sticking the kidney if I have a sample.
Diagnose that,
So certainly there could be cases that were missed, but also having 3 centers over a decade come up with less than 50 cases might suggest that maybe it's not quite as common as we think.
I agree.
I think the scenario also, that if we overdiagnose it when it's maybe a tangible diagnosis, then maybe we're missing some other reasons for it, which for us more often it's actually ureteral obstruction. That we'll see the cat has 4 millimeters of hylictasia, whether they have bacteria or not on their UA, and people will just treat them as if they have pylo, and maybe that could be from pylo, but more often than not we'll see when we get our hands on them, we'll ultrasound them and we'll actually find that their imaging is way more suggestive of nephroureteral obstruction than pyelonephritis. And
I agree with that totally.
We might be missing some of those cases that have mild dilation and just writing them off as being pyelonephritis when I'm not always convinced that they are.
So I guess the take home from that is pyelo is probably not as a frequent, or it should jump at the top of your head for a diagnosis. It's relatively, not that I'm saying glomerular disease is also a common diagnosis. I mean, that's also a kind of a rare bird as well. I see it a lot because of the affiliation with the IVRPS, but it also is a rare disease. But I think you're right. You have to explain the hypoalbuminemia and you have to explain the proteinuria. Even if they didn't have the UPC, they still had 3+, which I understand. If you had inflammation in your urinary tract, sometimes you write that off. But I would hope that that at least it would stimulate you to do UPC, and that would be pretty high for even just an inflammatory component to the urine.
What's annoying is that some of the labs will, like, you might say, I want a reflex UPC on this, but seeing that there were 5 red cells per high powered field, they're not going to give it to you.
Give you 2, yeah.
Which is stupid, because the literature firmly supports that you can absolutely still interpret your UPC unless it's discolored. There are 6 white cells. They're not going to give it to you. And so I try to lecture to our referring vets that, like, don't request the reflex UPC. Just order the UPC.
Just order UPC so you have the data. Yeah.
Exactly. You might say, well, it's 2, but there's pyuria and maybe bacteriuria, so maybe that's post-renal, but at least I know where it is, because if they would have had a UPC of 10, is that seen with pyelo? Potentially, but it's not typical. So I would have been thinking about other things right from the beginning if they would have had that piece of data.
Okay. Do you want me to move? So you guys pursued biopsy, or do you have more that you need to share before I?
So I think at this point I got a text message from JD saying I had a biopsy coming in the next day for me.
Right. The referring vet reached out to me with that lab work, and I looked back, I was like, I think this cat probably has glomerular disease. Send it in. We should biopsy this cat ASAP. So I think it came in the next day, first step.
Yeah. So that was the 22nd. We recommended renal biopsy. And I think, I have some pictures.
Okay.
Which I did not look at this until I was asked what his paws looked like. And then this is a blurry picture. I just got really excited that he had really foamy urine.
Yeah, you can see the lipid in there.
Yeah.
Okay, so for the pathologists in here, which we already talked about this disease phenotype in the email that I sent out to say what the case was going to be. When you see kind of swelling of all the paw pads, the digital pads, and oftentimes it's all 4 feet. The colloquial name is pillow foot. Or it's usually if you were to biopsy this is usually full of plasma cells. And so the biopsy is plasmacytic. Usually it's plasmacytic pododermatitis. Yes, Jessica Hokamp, I was getting to that. Thank you very much. Jessica.
Oh, sorry. So sorry.
It's okay. So if you guys are clinicians are biopsying and you're biopsying a cat, just take a peek at the feet and let us know if there's something going on with the feet. We don't get it's weird because we don't, if they have proteinuria and glomerular disease and they're getting a kidney biopsy, the nephrologists usually don't biopsy the feet. But I have working at Zoetis, ZRL, the reference labs, there are plenty of times where we'll have plasmacytic pododermatitis biopsies, and then we'll say, hey, is that cat proteinuric? And we're trying to get a number of cases together so that we can gather information about this cohort. And then, as Dr. Hokamp said, so you get a lot of lipid kind of associated with proteinuria, and so you get like this foam associated with the urine, and oftentimes in humans, that might be the first clinical sign that a person sees is they pee into the toilet and they look down and it's just full of foam and they're like, wow, I just made a whole bunch of bubbles. So there's plenty of times where people will go to their doctor because they're like, something's weird with my urine. And then they do the UPC or the 24-hour protein or urine collection, and that's when they notice that the protein is elevated in the urine. So sometimes this is the very first clinical sign that a human notices something's wrong with their urine. So we got that little foamy cap there. Cool. Okay, so you did some pred. Okay, and you went and started mycophenolate.
Yeah, pending biopsy, we sent him home on pred and mycophenolate.
And
let's see.
to follow up with what Rachel said, like I would put the plug in, like for any cat that you're gonna biopsy, like if it's not on your radar, look at their feet, grab a photo of their feet, because most, like Darcy, my wife, our dermatologist, you guys have heard me talk about her a lot, but like just seeing like the photo of the foot, she's like, yeah, this is plasma cell photodermatitis. Like she's not going to biopsy that frequently because she's like, that's the only thing that's going to cause all the feet to look like this. But to other people, maybe they're not going to look at the feet, right? Because very often these cats don't come in with lameness. You know, they're not clinical at all for their foot pad lesions. So you might not think to look, but when they're on their back getting their biopsy, perfect time to make sure you the paw pads and you know, maybe snatch a photo if you're not sure if that's normal or not.
Yeah, I think that's him anesthetized with our ultrasonography in the background.
Yeah. Perfect opportunity.
And I think like, so I know Dr. Quimby is Dr. Hokamp put in the text, Dr. Quimby has a collection of these cases as well. And we haven't actually aggregated all of them. I have a few of them that are in our system, and then she has more as well. So, I mean, she said, well, we don't have histology on the feet. And I don't think you need histology for this. Like, I think that this is a classic skin type lesion. So I think that you could be fairly happy if we've got a larger number of cases to say at least 10 of them were verified with histology of having plasma cells there. And the other 5, you know, did not yet have histology. But I think most dermatologists, like you said, are going to understand that that's what the disease is based on a gross photo. Okay, so I'm going to try to share my show more. Screen, window, or tab. This one. Let's see if you guys can see this. Oh, wait, hold on. That's not what I wanted to do. That was not it. I wanted, stop sharing that. Okay. Okay, so I'm trying to see if I can share the app that has all of the slides on it. We practiced in December to make sure I could do this, and it's not, let's see. That's what I want. Okay. So now you're seeing JD in retrospect, like all of JD's, probably like a boatload of JD. Okay, so now you hopefully are seeing you seeing the core, JD?
Yep, we can see it.
We can see it.
Okay, good. Okay, ooh. So a little bit annoying thing is that, okay, here's the H&E. So there's 5. Okay, so we got one great core. You guys should be seeing an H&E now. And the core has, it doesn't look like a normal kidney for the first first glance. We've got good cortex because we've got some good glomeruli in here. We have a lot of tubules, but they're kind of widely separated. And then we go down here to where we have a little bit more medulla and get back into the cortex. So if you think about this type of cut, we basically kind of got cortex from, let's say, the cranial pole. We skimmed along the superficial medulla, the outer medulla, I guess you would say, and then got back into the cortex on the other side. And so the glomeruli, I'm going to put, so last month I put a lot of the pathologists on the hot seat. So now I'm going to put some of the nephrologists on the hot seat. I know that Dr. Ross is here because she's already spoken. So Dr. Ross, do you think that this is a hypercellular glomerulus, a normocellular glomerulus, or hypocellular glomerulus? Hopefully you can still speak.
I was going to pretend I couldn't, but
you already spoke when you got onto the conference.
I know, busted. Just looking at nuclei counts, they're I'd say high-end normal-ish.
Okay. So
but
yeah, so
normal, but
I agree. So the thing is that we have kind of cutoffs we're allowed for the number of nuclei, and you're allowed to have 1 to 2 nuclei inside a capillary loop. You're allowed to have 2 to 3 nuclei inside of a mesangial zone. And what happens with this scenario is this entire little lobule that hopefully you guys can see me tracing with my arrow, that used to be one single capillary loop. And it's blown out because there are so many cells in here and a lot of matrix. So yeah, so like right here, we have the only circulating red cell in that entire capillary loop. Here we have like 3 red cells that are circulating in this particular capillary loop. So the kind of the take home point that I got whenever I was training at UNC is that if you look at a glomerulus and you can't tell where the capillary loops are, like you can't say this is a lumen, this is the basement membrane, et cetera, then you probably have a completely blown out capillary appearance. And because you have cells in there and you have matrix in there. So it even has a particular name in human nephropathology. We call it a lobulated pattern because this used to be a capillary loop, so it should have been really small, but now it's become an entire almost like lobule. It almost looks like a clover leaf at some points where you have these huge lobules all full of previous capillary loops that are now expanded by nuclei and by matrix. And so if we kind of back off and see, do all of the capillaries, do all the glomeruli look like this? Yeah, they actually have a lot. This used to be one segment. And maybe you had 3 capillary loops. Here's one, maybe here's another, and then here's a third. You even get to see where you have a little bit of nuclear debris. So some of these cells are undergoing apoptosis or necrosis or necroptosis, whichever one probably. But you have like cells that are actually dying in the glomerulus. And then there's a lot of extracellular matrix in there as well. So let's see what else. Again, as we're going through this, pretty much every single glomerulus has that kind of, lobulated appearance. And then occasionally you'll get to see red cells. So this is the only amount of perfusion that's going through this particular glomerulus. You guys all know that I don't really like the H&E, but I am going to quiz Dr. Brakel because she just got invited this time and she was not invited before accidentally. What do you think is the cell type that is in the interstitium of this region? Dr. Brakel.
Your H&E is tragic.
There's
Sorry, it's all hematoxylin. What is this?
Yes, it is. It's a little pale. So I agree with that. But you can't have a perfect stain every day.
Nuclear. Some of them look like plasma cells. Some of them look like lymphocytes.
Okay.
I think there's histiocytes in there too. But I don't know. I guess my guess would have been lymphocytes and plasma cells. But
okay. I agree. So right here we have a plasma cell, and then right here we probably have a lymphocyte. We don't have a lot of cytoplasm around it. My whole goal was to get us to say it's not really neutrophilic. And so a non-neutrophilic, and some people hate the word non-separative because it's just, it says basically anything but neutrophils. So the fact that we don't have a lot of neutrophils in here kind of also provides information that this is very unlikely to be an ascending pyelonephritis. If we had an ascending pyelonephritis, we would expect a lot of neutrophils in here and a lot of neutrophils kind of traversing and kind of getting into tubular lumens. And we don't really have that. We have interstitial inflammation and it's not neutrophil heavy. There was a reason for me to do that. All right, let's see what the next slide is. I think it's a PAS. Oh, come on. Okay, I have to go 1 second. Okay, we're gonna jump over to the Jones for a second, just because it's the next one I have loaded up here. So the Jones is really good for looking at basement membranes, and it's gonna be a very good help for us. So like when we were talking with Dr. Ross about like what used to be a capillary, this is outlining a previous capillary. So all of this is what used to be a single tiny loop. And let me try to find a normal, it's hard to find a normal one. Like maybe this is, even this is too big. Maybe this guy should be a normal capillary loop with its normal endothelial cell. But if you think about this structure that was that small and it became this large, we have a lot of material in the mesangium. We have a lot of endothelial cell damage. We have circulating leukocytes that are adding to this composition. And so this is a pretty good help to say that there is capillary damage and endocapillary hypercellularity. This particular capillary loop is also quite good because you can actually still see where a red blood cell would be circulating. And that little pink thing right there is probably the red blood cell that's circulating in through this capillary loop. So this used to be the lumen, or this is the lumen. And then if you see how thick everything else is in this glomerular capillary, that's because there are cells that are being pushed into the capillary wall. Oftentimes these are mesangial cells. And so the term for that is mesangial cell interpositioning. What that means is that you used to have mesangial cells here at the base. And once you damage your glomerulus, and there can be many causes for damage, it does not have to be a certain phenotype. But once you damage your glomerular capillary, the mesangial cells that should be native to this one little base start to transition and migrate out into the capillary wall. And so they end up within the basement membrane itself. And so sometimes if you're lucky, when you're doing the EM, you can actually catch this mesangial cell and the mesangial cell nucleus just hanging out here in the glomerular basement membrane. But remember, EM is quite a narrow section, so it's very possible that you're only going to see tiny cytoplasmic projections, and you're not actually going to be in that field of plane that has the nucleus. Whereas the histology is a lot thicker, so you're going to be able to catch those nuclei in that mesangial cell interpositioning. Let's go to this one and see if we can see anything else. Okay, so just to reinforce, this would be, even this is a slightly enlarged capillary, but we still have our lumen, and we have 3 little mesangial cells that are migrating through here. Maybe this would have been a normal capillary, but again, we have 3 nuclei that are hanging out in the lumen, and that is too many nuclei. So let's see if I can then.
And then they just want to make sure that
I have to, 1 second, I'm going to have to switch so I can get to the other stains. Let's go to the stain. Okay. Apparently I'm going to have to open them all by myself. Okay.
Who's there?
Okay, so this is the trichrome. The trichrome is really good for us to look at interstitial fibrosis. So I always kind of, when I first open the trichrome, I kind of get a gauge, like how much collagen is there, how much blue is there. I apologize if my dog barks in one moment, but the postman is going to be delivering something, and so my dog might bark. Okay, so you, let's see, who do I have on here? I'm gonna quiz. Oops, there's the mail. There, it's my dog, Cannoli. Shush, shush, stop. Yeah, sorry, apologize. Okay, I'm gonna mute myself. 1 second. Oh, I can't even mute myself very easily.
I mean, it's okay. JD's in a clinic, you know, they've got.
I know, but I don't want my
patients going on
to stimulate his dog patient. Like, what if, all of a sudden it sets off his patient? And I totally lost what I was trying to look at who else was here. Okay, Becca McKee.
Hey.
How close do you want the tubules to be to one another?
Pretty dang close to one another.
Yeah, so you really want a tubule to be back to back to another tubule. And the only thing in the middle is you want the peritubular capillary. Okay, so let's go back to showing my whole thing. So if you were to look at this, as you are looking at this trichrome, do you think the tubules are back to back, or do you think they're separated?
They look separated in a lot of the fields.
Okay, perfect. So that's exactly what the fibrosis is doing. So here, this is actually a pretty cool field. So you have a previous tubule. This is probably proximal based on the fact that it's columnar, it's got a brush border. Look how far you have to go to get to that peritubular capillary. So think about anything that's perfusing this interstitium. So red blood cells are going through this peritubular capillary, and it's trying to oxygenate this tubule. It's also trying to take any toxins or reabsorbed material, not even toxins, like normal albumin that the proximal tubule would reabsorb has to get from here all the way through this dense interstitium to get back to the peritubular capillary. So the peritubular capillary is quite important in supplying and oxygenating and also taking away materials from the tubules. So sometimes you can't see the peritubular capillary. We do have a study that we did with Dr. Quimby and Renee, where we actually stained the peritubular capillaries and assessed how close they were to the tubules. And we could see that cats that have CKD, no surprise, have quite a distance between their peritubular capillaries and the proximal tubules, which is probably part of the pathogenesis of how CKD perpetuates. So there's a lot of fibrosis. We're going to go, and the medulla always has a little more collagen than the cortex. And this right here are all the vessels that are running along. These are considered the vasa recta. So they would be running along next to the loops of Henle. And they usually kind of have this big kind of group of them. And then they are basically the part that is going to be reabsorbing from that loop of Henle that's doing a lot of the reabsorptive work. So here's another group of capillaries that are doing that, the vasa recta. This is what a red blood cell looks like on a trichrome. It should look kind of slightly yellow-green. Okay, let's get to the glomeruli because that's the fun part. Glomerulus is kind of boring. Let's go back to our fun ones. Okay, so again, a lot of matrix. So a lot of that blue is going to be mesangial cell matrix and mesangial matrix that's synthesizing. The other thing that's kind of standing out to me, mostly because I look at a lot of these, is that there seems to be some material kind of along the capillary loops that's staining a little red. And honestly, from this picture, I wouldn't be able to tell you whether or not it might be podocyte cytoplasm. Here's our little podocyte with podocyte nucleus. So it might be like just really a spread out podocyte cytoplasm, or it could be deposits. And so, and we know we have a membranoproliferative pattern. So deposits seems like they would be possible. But yes, not much else except for this one glomerulus here. I think this used to be a glomerulus, and I think it's completely blown out and full of red blood cells. So that one probably is a glomerulus that basically exploded. And we'll go to one more stain, and then I don't even know if I really want to go to the stain. Let's see one second. It's just the PAS. I'm going to have to pull it up again. So I'm not going to pull up the PAS because it's going to take a little bit of time. But I'm going to go to now show you the, let's see. I do want to stop sharing while I'm showing you things that are like budget stuff. Stop sharing now and then get my other thing. Okay, so I had a membranoproliferative pattern. I told them it was probably going to be immune complex mediated. It's not that many other things that do that in veterinary medicine with that type of pattern. I'm just going to pull up the report because it has all of the pretty IF images and electron microscopy images. Let's do one more share. Okay, no, this one. Okay. Okay, so here again is a little recap of our histology, and I will make this bigger. That's our blown out glomerulus. You can actually see in the PAS of that blown out glomerulus, this is probably the vascular pole that has fibrinoid necrosis of that vessel. And then you just have fibrin and proteinaceous fluid kind of just blowing through that, that region. And then on a trichrome, the fibrin's usually orange-red. Okay, so let me go to the IF quickly. So the IF it was interesting. It had a lot of IgA staining, which is something that we don't often see. IgA is usually, in many cases, negative, but there was a lot of kind of positivity with the IgA. There's also granular staining with IgG. And remember that histologically, this whole thing right was one capillary loop because remember it had that lobular pattern. So in this particular thing, we have all of this kind of granular staining along that lobular pattern. And so these are all previous capillary loops that have granular staining. But again, we have a positive IgA. We don't have a working C3 for cats. The antibodies that stain canine C3 do not label cat C3. So it's really hard to prove complement activation. We just assume it's there. The lambda light chain is, I'm getting a little bit of an echo, so I'm not sure if I'm echoing to you guys. I apologize if I am. But the lambda light chain is going to basically be part of any immunoglobulin. So it's going to be part of IgA, IgG, and IgM. And that's why it's always pretty strong when we have any of those things. The IgM it's always pretty strong as well. So a lot of that granularity along the capillary walls. But again, remember, this was all one capillary and it's full of cells. And then we'll go up to the EM. Okay, let's go fast. Okay, so remember I said with the histology in this type of pattern, it's really hard to tell where you are in a glomerulus. And so when you're looking at a glomerulus and you're like, am I in a capillary loop? Am I in the mesangial zones? I'm not really sure. Then it's pretty likely you have a membranoproliferative pattern. You have that lobular pattern where like so many cells are present, you can't even feel where the original capillary lumen was. So for example, here's our GBM, and it's not too bad. There's not a lot of remodeling at this point. But we have these electron dense deposits. Here's one, here's one. This is all deposit down here. Some of this is just kind of ooze plasma proteins, but all of these densities right here are deposits. And they're quite small. When you have a really aggressive MPGN, the deposits themselves can be very small. And they are still attracting a whole bunch of inflammatory cells to come to this previously capillary. So I'm not sure if this was the original lumen and now we're just distended with cells. Look how many nuclei we have in here. Here, I think, so I can tell you this is the GBM. It's almost like it would be a good case to do when we color the glomerular-based membranes like we did in our atlas. This would be a good case to do because it's really hard to actually pick out where the GBM was. Here, we definitely have a neutrophil. It has a polymorphonuclear nucleus. And we have little bits of kind of swollen granules. This neutrophil is dying. It's basically, getting rid of its granulars and going through netosis. I guess this is an EM image of netosis. So every single capillary loop looked similar. And so it's hard to find the deposits themselves because they are quite small, but they are there. So here's one. Here's these tiny ones. And this is true in human really bad crescentic ICGN as well. Like you have to hunt to actually see these tiny little deposits. We just have like a weird filter right at this one part. So it's not, I think if you had a really bad, if you have a membranous, I think it can just smolder for so long that the deposits can get really big. But with this type of disease, it's so acute and so rapid that the deposits actually are quite small, even though they are there. Like here, hopefully you guys are still seeing these deposits right there. Okay, so I was confident it was immune complex GN. I will stop sharing and we can talk about what happened with the case. Again, I apologize for my dog. Oh, friendship might have been called away. Hopefully. There.
I think they're muted.
Yeah, I think they're muted. It's hard to work and actually present at the same time. Steph, like you have done so many of these cases and you're like always like dialyzing at the same time.
It's a little chaotic in here sometimes. Okay, so let's see. He did, okay, this is at the RDVM. He was like about 10 days after I sent him home on the pred and mycophenolate, he started having diarrhea. just wasn't eating that great. His energy wasn't that great. So I ended up stopping the mycophenolate, and I think at this point, maybe we had like the preliminary biopsy back at least. So I sent him on a mg per kg of pred, and I increased him to 2 mg per kg of pred, and said, let's see what happens with more pred and no mycophenolate, and if the GI signs get any better. Like his azotemia really hadn't changed much at all, and his total solids was the same. I did not get an albumin that day. We started some Serenia and an appetite stimulant, and then I went to Costa Rica for a week. And while I was gone, he was euthanized. So.
Was he euthanized just because he failure to improve, even with pretty good knocking on the immune system?
Yeah, and I hadn't added into here. He had rechecked with the RDBM, and his azotemia was maybe slightly worse. I think his creatinine was like 4. He'd lost more weight. He was not eating enough. He just didn't feel very good. I think maybe this was like a first time owner, and like when we talked about subQ fluids, he started to get very overwhelmed. So they decided to stop.
Yeah, and I think from a pathology perspective, there was some pretty significant scarring. So I think it would be really hard to reverse a lot of that change. So it's not like even if you get rid of the immune complexes that are, causing the endocapillary hypercellularity, that you could really reverse that fibrosis. And this cat might have gotten over an acute episode, but he was going to have really bad CKD at 1.5 to 2 years old. And so, I mean, with that amount of fibrosis and that young, and I don't think I realized how young he was until I started putting all these cases together, and they're often like 1 to 2 years old, and they already have pretty bad tubular interstitial scarring. So, and I don't know, like it's very possible that happened a long time ago, and this was smoldering, and then eventually you had a big hit. I don't know if there was, kind of recrudescent disease, but there was a lot of interstitial fibrosis in this biopsy. So
they did note that his litter mate was like twice his size too. So he was like,
oh,
so
had he always been a runt, or was he?
For as long as the owner had him, he was the smaller cat. The owner had him since he was pretty young. I don't remember the exact age, but
okay. So I will kind of share what we've collected. Oh, did you have any other things?
And the only other thing I was thinking too is that even just looking at the capillary tufts in the glomeruli, that it's really hard. If you had to guess what that cat's creatinine was based upon histology, I probably would double the creatinine that he actually had based upon just having so few open capillary loops that were available for filtration. So that's the other part that I would also be concerned about, that even if you could correct the deposits that are there, there's a lot of injury, and that's a lot of opportunity for glomerulosclerosis as it heals and either repairs or becomes sclerotic. That is a cat that could still have a persistent reduction in GFR, or still some pretty heavy proteinuria at the end of the day, even if immune complexes are no longer present.
Yeah, I agree with that. It was going to be a hard one to come back from, and so I think, although it's a sad outcome, I don't know if there would have been an improved one even if he had survived the acute episode. He was going to be, and so if you think about scenarios where we're looking at kidneys from cats that are 5 years old and they have such significant scarring, there had to have been a transient episode at some point. And I'm not saying it's always glomerular disease, because often glomerular disease is not the most common thing, but always remember that, like, judge fibrosis associated with the age of the cat, right? So don't always just say, oh, it's just a chronic CKD thing. If the cat is young, the cat should not have really bad interstitial fibrosis. So as pathologists, always kind of keep that in mind. And so then you have to search back and say, well, are the vessels okay? Is there radiating scarring from the pelvis, which might make me think it's ascending pylo or a stone or obstruction or something like that that's causing this kind of backup. So always try to at least find an etiology. I get really impressed because, you know, there's plenty of times where I'll see 17-year-old cats and they have only very small amounts of fibrosis. They're going to have some, but, you know, I think it is, as a pathologist, you should always ask yourself, does this fit with the age of the cat? I did put together a really quick list of the cases that we found. Yes, yeah, please do. So Dr. Amerman put a perfect question on there. And so we do have a blurb now at Zoetis Reference Labs because we see plasmacytic pododermatitis that says, you know, worthwhile to check a creatinine, an SDMA, and a UPC with urine sediment, just recommending next tests for the cat. And so we do have a boilerplate. I haven't had any, and we always actually ask them to contact me. I haven't had anybody actually send me information about it. It might be that once they get the biopsy back, they're like, we're not going to do all that. That's very possible, but it's fine to put that information to say, like, let's just get baseline urine statistics, and then have that. And then if they need to contact the IVRPS, it's good to have as a thing. We have 6 cases, I think, that are that we have in our database. Let's see, why am I not sharing?
And Rachel, as you're bringing that up, I feel like we have a handful of dogs. Maybe I can think of 5, maybe, from looking through the database with IgA nephropathy. Do you think that there's anything unique about how intensive IgA staining that this case had as well too, or do you think it's just going along with everything else that's going to get blasted through those ugly capillary loops?
I don't know. And for some reason, I'm just going to say it's not letting me share really quick, but I can send out an email with the thing. For some reason, it's getting mad at me. But I don't know. IgA is not as common. I actually see it in some staining in dogs that have, you know, a few mesangial deposits, and the IgA is stronger than the IgG. For example, oh, that's letting me do that. Okay, I just had to actually do there you go. Okay. Hold on. Let's see. I'm just gonna say share in screen. And then I'll pull up the thing. Okay, so I do see IgA rarely. In humans, the IgA is the most common cause of proteinuria, and or I should say, yeah, glomerular disease proteinuria. I should say glomerular proteinuria. But the reason it's seen so commonly in humans and not seen in small animals is that humans and primates are the only ones that get that make the IgA variant. And I'm gonna blank on it. There's IgA1 and IgA2. There are 4 IgGs. But humans make, I'm pretty sure they make both, and dogs and cats only make one of them. And I can't remember which one it is off the top of my head. But the one that humans make and primates make, but dogs don't, is the one that causes, or is most likely to be the cause of IgA nephropathy. And it's really freaking cool because they finally figured out the reason IgA nephropathy happens is that there is a variant in the glycosylation pattern of the immunoglobulin. So they're actually hypoglycosylated. So it's not a genetic mutation or genetic variation in the IgA itself. It's just that it's abnormally glycosylated. So therefore, extra portions of immunoglobulin are exposed, and IgG binds to the IgA. Like IgG from that patient is like, oh, this is a weird protein because it's hypoglycosylated. And so it binds to the IgA, and that's how you get IgA nephropathy in humans. We don't have that level of technology to know if that happens in cats. There are some types of IgA in humans that are from the typical IgA that is present in all species, but most commonly it is due to the isoform that only primates express, or primates synthesize. So this is our really quick group. One of them is a urine only, and I know Dr. Quimby has a lot more cases. And Dr. Sarkin, you're on this call. We can make sure we get her information so we can add more cases to this list. But you can see, for the most part, a lot of them are young. We have one that was a little bit older. And we had a variety of diseases. So we had 3 of these that have ICGN. One actually had amyloidosis, but glomerular disease with proteinuria. These other 2, this right here, was a weird case. It's an old case. Haley, it was way back when I was a resident, so it's not, it would be really, really old for Penn. But it definitely had the podocyte paw pads, the plasmacytic paw pads. But when they went to go biopsy the paw pads, the cat actually became hypotensive and had development secondarily the papillary necrosis. I don't think we ever had urine on this cat. So, but they went to go biopsy the paw pads, and then they messed up the cat by having a bad anesthesia event. So that one kind of fits weirdly. And then this one, I think this OSU case, that it previously had an elevated UPC, but then by the time they did submission for the SDS page, it had actually kind of returned back to fairly normal. And so the SDS page pretty much only showed tubular injury, but I know there are plenty more that have evidence of glomerular disease that Quimby is kind of having, a collection of that she's following. But like I said, a lot of times she doesn't get biopsies on these cats, or she doesn't get, even if she has tissue, she doesn't always have the biopsies from the paw pads. So this is kind of what we have right now, but it would be great to add more cases to this and at least kind of get something in the literature about maybe the external manifestation is a little bit of a marker that there might be internal disease. And save. Okay, I think that's it. Do you guys have any questions? I'm not looking at the chat. Let's see. Okay.
Dr. T had a question. Maybe JD, I don't know if you're able to answer this. I was saying that I think Quimby might be a good one to ask since she's seen a number of these.
Oh, so like, could it be that the pododermatitis exists prior to the development of glomerular disease, time frame wise? Yeah.
Yeah, it's a good question because I certainly know that our dermatologist isn't running urinalysis on all of those patients, and
they should.
And we are forgetting to look at the feet sometimes of cats when we biopsy them. So it's hard. I don't know if we have a really great timeline, but I think you could certainly argue that there could be either one that could come first. It's probably easier to make a timeline that maybe there's lymphoplasmacytic dermatitis or pododermatitis, and then that has led to this upregulation of the immune system, and if there's an aberrant response in the kidneys. So perhaps if you catch their pillow feet early and their urine is clear, maybe they will still have a chance of developing it later. And if it's, so I would probably say, great, you get your urine right away, you make sure that there's not any protein, but that would still be a patient that in another month or 2, I would certainly want to check a urine and think if you end up checking 4 urines over the course of the next year and the pillow feed is well in clinical remission and the cat's never been proteinuric, then chances are it might have a good likelihood to not be affected. But I would be nervous that you could potentially have clinical remission of the plasma cell pododermatitis, but then maybe get proteinuria months after that. So I would basically plant it that this should be something in cats that we just want to probably check a urine on them quarterly, at least for the first year after the pododermatitis has been observed, and then maybe longer. Right? That's probably a good starting point.
Yeah, I agree. And since they're so young, they have so much time. I don't know, 4 of the 6 were pretty young, so. Okay, we are right at 2:00, so I do have to end because I have to go to another meeting. But please send me emails if you have cases that you would like to aggregate together. And sorry for any of the technical difficulties with me still trying to figure out Teams. Zoom is a little bit easier, but Teams allows everybody to join. And sorry for my dog barking. I apologize for that scenario. So. Okay, I'll see you guys next month.
See everybody.
Bye.
Thanks.
Thanks.